Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live weekly webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box and be visible to all of the attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin and Anishinaabe people. We are grateful to have an opportunity to be present in this territory. Today, we're delighted to welcome Children's Healthcare Canada member Sick Kids and today's sponsor, Mallinckrodt Pharmaceuticals, for Net Worth of Networks, a Quality Improvement Tale. As mentioned in the introduction video, please type your questions into the question box at any time. I'll prompt you via the chat as well, and I'll pose questions to Dr. Shah at the end of the session. I'll now introduce Dr. Shah. Dr. Prakash Shah is a professor in the Department of Pediatrics and the Institute of Health Policy, Management, and Evaluation at the University of Toronto. He holds an applied research chair from CIHR in reproductive and child health services research. Currently, he's the director of the Canadian Neonatal Network and an international network for evaluation of outcomes in neonates. It's my pleasure to pass the mic to Dr. Shah.
Thank you very much, Paula. Good morning to everybody. And thank you, Children's Healthcare, to give this opportunity to me on behalf of the networks that I chair to showcase our work that we have been doing over a number of years, and present you some of the information that we have learned and how we have improved the outcomes of the newborn babies across Canada. So my objective is to tell you what Canadian Neonatal Network is, what do we do, how do we do, tell you about our national experience, learning for over the number of years, international experience, as well as what are the facilitators and barriers in child health care that we have identified in terms of improving outcomes. To take you back, Canadian Neonatal Network existing from 1995. We were fortunate enough to celebrate our 25th anniversary last year. And this is one of the first paper that came out from the Canadian Neonatal Network, indicate when we started collecting data about the babies across the neonatal intensive care unit in Canada. At that time, there were 16 neonatal intensive care units that participated, and what we identified that despite being a neonatal intensive care unit, there was marked variation in mortality between the sites. The mortality varied, the accrued rate varied from 1% to 10%. And that sparked the question that, okay, tell us which is a site M and site J, because parents wants to take their baby to site M and site J, and not site A and site N. And that led to a significant amount of work starting from 2002 that I will share with you. We realized in 1995-96 that we needed a network of individuals and organizations which are working or creating pathways for improving outcomes in non-hierarchical common terms. We all had common issues to improve the lives and outcomes of the babies and families. And we wanted to pursue this particular goal proactively and systemically, however, not losing the commitment and trust from people across Canada. So in order to do that, we wanted to build some social capital, recognizing that everyone is doing their best possible job, encourage and foster collective values, and learn from each other, and design the network so that it evolves over time. And I hope I will be able to convince you at the end of the day. We just didn't want to be just a data repository. We wanted to convert the data and learn from data step by step so that we can get wiser and wiser. We are not totally wise yet, and that's what we are striving and continue to work for. And I hope in this next 40 minutes, I will be able to tell you how we have converted data to information, engaging community, collaborating, developing knowledge, implementing knowledge, and getting wiser and wiser. I could not do this without recognizing or acknowledging Dr. Shu Lee, who in his vision established the Canadian Neonatal Network in 1995 out of Vancouver, British Columbia. And the mission at that stage was that we become a collaboration between the neonatal intensive care unit across the country. So it was established in 1995 with a goal of improving quality, improving outcomes, and improving care that we provide to babies and families. At that time, there were 16 neonatal intensive care units across the country. Currently, there are 31. So we have nearly doubled in our capacity. But I'm proud to say that all 31 neonatal intensive care units are member of the Canadian Neonatal Network today. So all babies admitted to any of the tertiary level care in ICU, we get information to learn from each and individual babies. The activities that we do at the network, the core is benchmarking and trend evaluation. We want to see what is happening at a national level, what are some of the usual and unusual trends that we are observing, and what are the reasons for those trends and how can we improve the trend in our favor. In addition to that, we do a lot of research and publish information related to the learned objectives from the network data. We also do health service evaluation, meaning thereby which areas, which health services providing what kind of care and what are the avenues for improvement. We train and mentor a number of multidisciplinary researchers as well as trainees. We do international collaboration. However, today my talk will be focused mostly on quality improvement work that we have been doing for last 17 years now. Just to give you background, we collect data from each baby admitted to the neonatal intensive care units across the country and convert this data into information, which is being fed back to individual units on a live as well as regular frequent intervals. We benchmark on major outcomes that we want to improve, i.e. survival without disabilities. We continue trend analysis. And at this stage, still we are anonymous in reporting as to which center is performing in which way. To give you an example, to give you the magnitude, this is the number of babies admitted to the neonatal intensive care units every year or in a particular year in different units across Canada. So as you can see, we are not all same. We have unit with less than 100 admission, and we have units with more than 1,000 admission. We have units which admits the babies directly from their birthing place, and we have units which admits the babies not from the birthing place, but as an outborn babies. But we all are in together to understand how can we improve the outcomes. One of the report that I'm showing you here is nosocomial infection. What is the rate of nosocomial infection per 1,000 patient days among babies less than 33 weeks admitted to the NICU? And as you can see, it is variable. There are units with less than 1 per 1,000 days, and there are units with more than 5 per 1,000 days. But this is the key information that every unit gets it on an annual basis. They look at this information and plan their subsequent steps in the direction so that the outcomes can be improved and be better. So this becomes a challenge for some units, as well as challenge for other units to maintain and sustain their lower rate of infection. Our real question comes when we look at this kind of graphs is that, okay, well, my unit is big unit, my unit gets sicker babies, my unit gets babies with the complex situations. So we do a lot of analysis to control or adjust for it. And what you're seeing in this funnel plot is that each dot is an individual unit. The purplish or the gray, the line that are like parabols on the either side of the central line of 1 indicates 95% confidence interval. And what you see here is that we would like the unit to be at 1, meaning thereby your expected rate of morbidity is same as what is observed. If your observed rate is higher, you're on the upper half of the graph. If your observed rate is lower, you are on the lower rate of the graph. And the size of the unit is also accounted for by being on the left side to the right side, being a bigger unit. So by this way, we can compare in an adjusted analysis, what are the outcomes for different units. And as you can see, majority of units are performing within those 95% confidence limit. And I will show you further slides. If your unit is happy with where you are, let's say 13, for example, then you will see that in 1 year or 2 year time, all of these other units which are on the top will work to improve their outcome and will be bottom, and you will be outside of this parabol. And that constantly keeps stimulating the units to do better and better. As well as you need to look at number 18 and 21 to see that these units have fared very well and what can we learn from them. We also look at the trend analysis at a country level. So this is the survival of the babies born at different gestational ages. The bottommost worm is less than 23, meaning they're by 22 weeks, and then the gestational age increases. The key features from this particular graph are that despite what people think, by 25 weeks, we have achieved 80% survival for last 10 years. And at 27 weeks, nearly 90% survival. Those are very astonishing figures if you look at the world level. But importantly, even at 22 weeks in 2010, none of the babies survived, whereas in 2019, 40% of them survived to go home. And that's a big jump that happened slowly over years by improving care. And with that, each individual gestational age above that also started to show improvement. And that's what we feed back to our constituents. And I will show you some example as to how we are faring in reference to the international standards. We produce our report annually. They are available on our website, CanadianNeonatalNetwork.org, freely for anyone to go and look and evaluate on an annual basis. But as I said before, today I'm going to concentrate my talk to quality improvement, because that's the title of that's what I want to share. So we adopted a model called EPIQ, Evidence-Based Practice for Improving Quality in Neonates. And this is based on a Parihas model where you engage the teams, you communicate, you look at the data and come back and evaluate practices and go back to the engaging the team. In this process, what we did, 4 major tasks were promoting dialogues through teams, sharing and evaluating data, sharing best practices, and sharing intervention and their results. So this has been a long journey. We have gone through iterations of this program in improving the care from 2002 to 2021 and ongoing. And I will show you the snippets of the results of all these phases as to what cumulative gain we have attained over time. So take yourself back to 2002, 2001. This conceptual model that was developed with the backbone of Canadian Neonatal Network, where we had data. And we asked our colleagues to review their practices. We asked them to look at their processes as to how these practices are being implemented, identify the roadblocks, barriers, facilitator, analyze them, and plan a quality improvement cycle to improve anything that they find in their unit that was not happening the way they wanted to. Collect some local information as to what is happening to the process measures. And then at the central level, we continue to feedback them the outcome measure so that they can look at it, implement it, audit, and come back to the data and reanalyze whether that particular intervention functioned in their unit or not, and what modification they needed. So if you go back to 2002, you could imagine that at that stage, quality improvement was a kid on the new kid on the block, and a randomized control trial were the only way that you can do anything that can change the way we manage patients. So we first did a cluster randomized control trial to prove this concept. Before we go to the details of the cluster randomized trial, during that trial and before and after, what we did some local activity, we did some network activity, and dialogued between the local and network level between the people of different unit so that they can understand what is happening not only in their place but other places. So locally, we asked them to identify the focus or need, create some quality improvement team at a local level, get their institution to buy in, and then look at their data and feed them. At the network level, we identified the collective areas of interest, which at that time I will mention in a minute. We trained these teams at individual sites. So we got them together, we trained them as to how to implement a quality improvement cycle in their own unit. We supported network. From the network, we supported sites as to what they wanted to do and collectively reviewed what everyone has produced. After that, we listed some of the best practices that a particular outcome can be mitigated with, then continued to track the data, share experiences, got people to come to one platform on an annual basis and tell all other colleagues what they did, how did it go, what went right, and what did not go well. So our first focus was to reduce infection in the unit, as well as reduce the chronic lung disease. So these premature babies, when they're ventilated for a long time, they develop what is known as chronic lung disease, which has significant implication for the pulmonary outcome, as well as neurodevelopmental outcome later. So at that stage, we had 12 units which elected to participate in this cluster randomized trial. And 5 units indicated that, look, we don't have resources. We just want to see what happens. We randomized those 12 units and told one group of units to say, you concentrate on infection and reduce infection in your unit. And another group, we said, you concentrate and reduce chronic lung disease in your unit. Finally, we had around 3,000 babies in each group, as well as 1,100 babies who acted as control. After 3 years, what we found, the group which was working on infection reduced infection in their units by 34%. Now, infection is one of the biggest culprit for developing chronic lung disease. So it also reduced chronic lung disease, or BPD, in the same group. The group which was working on BPD, there was no change in infection, but they reduced their BPD by 15%. It's not that the intervention group did better. It's the fact that the control group did not have any change during this period. So what we learned, that it is effective at reducing the outcomes in NICU. If you target one outcome, you can improve the multiple outcomes. And it probably might be an effective and cheaper way than traditional method of identifying one intervention through one randomized control trial over a number of years. So this led to tell us that this concept is a scientific concept of improving outcomes in the baby. Of course, we were very elated, we were very happy, and we thought that we have put the whole country in the right track. And even the control sites came and say, tell us what you did, give us the list of the things that you did, and we will implement. So we were happy. We said, okay, let's see what happens over time by just adopting what worked in the previous randomized control trial. So we wanted to see whether this effect is sustained beyond randomized control trial. So again, more units were interested. So we got 23 units to come. So 11 that were in RCT and another 12 which were not in the randomized control trial came. We trained them how to do the quality improvement. We told them these are the list of the things that potentially worked. And we told them, okay, we'll see you at the end of 2 years. No constant reminder, no constant intervention were applied during this period. Sorry. So what we found, the hospitals which had the infrastructure and the capacity to build teams and continue working in teams and creating cycles and improving the quality, sorry, continued to improve. Whereas the hospitals which received just paper list of intervention or list of ideas that may lead to reduction in adverse outcome, there was nothing. There was no immersive engagement during this 2-year period. We did not keep on going back and asking them that, okay, what you did, tell us, come back, learn each other, sit together. It was just left that if I give you bundle of practices, does it improve outcome in your units? And unfortunately not. So we learned that just disseminating the results doesn't work. It needs reinforcement. It needs teams within the unit. And without the multidisciplinary input, without development of the teamwork, there may not be an improvement that will happen. So you need immersive engagement at a local unit level for quality improvement to work. So we could not leave that alone. So next we planned a larger study with engagement of all neonatal intensive care unit from 2008 to 2013. We targeted high-risk babies, the babies who were less than 29 weeks gestation. We targeted 5 major morbidities because we could not do a randomized control trial. This was not going to be feasible that any unit will participate and not do quality improvement activity. And we wanted to see how these babies fare in the long run. So we planned this for 5-year time frame. So we needed to do little more work in terms of developing systematic review process for each of this morbidity. We developed virtual research community where people can engage. We developed EPIQ indicators for success or improvement. Lots of teleconferences, lots of training workshops, and lots of face-to-face meetings that happen. Just to give you an example, when the premature babies are born, what they receive is called surfactant if their lungs are immature. So this is one unit who decided that, okay, well, it takes in our unit, from the time that a baby is born to the time that baby receives surfactant, 14 steps that baby has to overcome before baby gets what baby needs. And this is too late. This is delayed. So what they decided is to, let's see, where are the blocks? So they reviewed literature and they wanted to cut it down to less than half an hour. They set up working group to facilitate change, identify obstacles. They obtained agreement that surfactant is a drug, but that can be stayed right at where babies are being born, not in the pharmacy. And then respiratory therapists are able to give it. And they developed the whole process map. And now babies were getting surfactant within 3 steps. So this is how we trained for them to empower them to conduct their routine quality improvement activity at unit level. We didn't tell them that this is your problem, you should fix it. And they basically collected data and they showed that previous time to get surfactant was 90 minutes and it came down to 32 minutes. A success that they shared with others, and others who were struggling for this started to adopt this practice. So what did we find? So we had a baseline period of 2008 to 9 and then intervention years 1, 2, and 3. And what we found was that there is 37% reduction in babies having death or morbidity in babies for less than 29 weeks in Canada, a 37%. However, we also learned that most of the improvement occur in the babies who are 26 to 29 weeks and not in the babies who are 22 to 25 weeks. So we were happy that there was improvement, but we were also learning lessons. Sorry for this horizontal bar, but what we are saying is the EPIQ is effective in reducing multiple outcomes. If you target one outcome, it may affect another outcome. And most importantly, it is not only scientific, not only needs engagement, but it is generalizable because we went to 25 NICUs across the country. Of course, we didn't want to just sit together, sit tight and let it happen. We immediately launched EPIQ 3, which is to sustain these efforts in the country and to continue to develop true sense of collaborative engagement, as well as empower units with sustainable quality improvement methodology. So we continued that with a lot of modification as to targeted outcomes. We provided feedback to the individual units saying that, look, yes, you have improvement, but these are the areas that you didn't improve and you should target this in the next cycle and so forth. Also had individual site visits. So we asked units which were struggling for a particular outcome to go to another unit which were doing better in that outcome, sit together, learn, watch them how they do it, come back and see what you can implement at your site. So with that, over 2008 to 2011, again, another 28% reduction in odds of composite outcomes. Still struggling for the smaller babies, but at the same time, as you see, the survival in the smaller baby continued to increase during this period. And that is what was reflected because more babies were surviving and there were instances of more morbidity coming with the survival of the youngest babies. We also saw improvement in certain outcomes and static results in certain outcomes. And those were the ones we targeted. I must tell that all the conclusion of this process is that if for every 60 to 70 treated babies in the unit in Canada, we had 7 to 8 less babies surviving without major morbidity. This allowed us to conclude that EPIQ is not only scientific, generalizable, but it's also sustainable. Again, we embrace the concept of networking to improve quality. And it reached to a stage that we had administrators coming to our annual meeting from different NICU because the frontline workers were going back to administrators and asking them, oh, I need to do this because I need to EPIQ state that. And they said, what is this? And they came and they learned and they realized the potential that we have in improving outcomes of the babies and the families. However, pure scientist in me will say, well, yeah, I mean, is this what you did? Or is this just a result of time that you have, what you have seen is improvement that one would see if you just concentrate on looking at, if you just look at the outcomes of the babies over time. So what we did was we looked at that to see that, okay, yes, that's a valid concern. And how can we say that it is because of EPIQ and not just the time? And I will show you two important examples to validate my findings. This is the whole process map that I don't want anyone to read, but from 2002 to 2017, what are the different key interventions that we have done in individual outcomes or individual improvements. But this slide will tell you all. This is on the horizontal axis is the time, and on the vertical axis is the outcome, being survival without morbidity. All 4 worms are different gestational age, the lowest one being 23 to 25 week, 26 to 28 week, 29 to 30 week, and 31 to 32 week. This is a process control chart and should be read in the phase in that framework and not as A versus B or 2004 versus 2017. Whenever, if you see there are 8 points on one side of the line, horizontal line. So you have orange, green, red, and the blue horizontal lines. And if you see 8 consecutive points on one side of that line, it indicates that we have spatial cause variation, that there is something happening in this process that has led to the change. And this is prime example of showing you that change occurred during this period, not just because of time, but it has improvement associated with it. And when we look at individual morbidity, you can see they all started to come down with 8 or more points at the lower level in most of the outcome, except 1 or 2. And that was also associated with improvement in the processes that we wanted to implement, such as making sure that the babies are not cold, making sure that the mothers are getting antenatal steroid, making sure that the babies are not getting postnatal steroids as frequently as we want, likewise. So there was process improvement and there was outcome improvement. And that basically has practically led to between 20 to 40% improvement in various outcomes in Canada over 2003 to 2017. This is one example of one finding to validate my finding that we did better. But 2 important other points. One is a real achievement. What real achievement I mean by is that if you see all the units, they are all within those parabolic 95% confidence limit, meaning thereby the variation that we saw in the first paper in 2002 has practically disappeared. It doesn't matter where you are being cared for. All units were functioning at a similar level in terms of improving outcomes. And that brings to the quality improvement paradigm. When quality assurance is that you have certain units which are performing worse on the right side of this graph and certain units performing better. What you do is basically you shut down those units. That's quality assurance, because you can't let this worse outcome happen. We can't do that in a wide geography of Canada. What we can do is to improve. So what you see here is that there is always a distribution where unit could be here or here. What we want to do is to bring all the units towards the left, meaning thereby better side, as well as close as together, so that there is not much variation. So you improve outcome, bringing the units to the left, as well as reduce variability between the units in terms of outcome. And that's what you saw in this picture, that we have brought units together within that paradigm. Of course, this did not go unrecognized. Everyone in the world were watching what happens in Canada and learned from us. They came to our meetings. They were swept by the amount of engagement and amount of interest that came from each and every single unit. So Sweden started a program. We helped them to start SWAPIC. We had South American countries who are doing currently, including China, for infection. We have a follow-up of these babies where parents are engaged in quality improvement activity. It's also running in Malaysia, Australia, and Egypt. And in addition to that, we also expanded in Canada, because this is what we did once the baby was out. And of course, our colleagues, obstetricians, learned about it, and they said, well, why can't we be part of it? why can't the improvement starts after the on one side of the umbilical cord and not the other side of the umbilical cord? So we expanded, including the perinatal health group. So our perinatal colleagues, obstetrician, maternal fetal medicine colleagues across Canada, to develop what we call Canadian Preterm Birth Network, where we are participating with them to see that, okay, how can we optimize antenatal steroid? How can we optimize cord clamping time so that the baby gets the best out of it? And how can we judiciously use antibiotics during the antenatal period so it doesn't affect baby's microbiome and doesn't affect baby's outcome? So we leading this, and we are seeing significant changes happening with the two sides coming together. And as I mentioned, internationally, so with this information, we went to the international community and asked them that would they be interested in creating something like this to understand what is happening between the countries, learn from each other. Because during this period, Japan was producing results that were significantly higher in terms of survival compared to the rest of the world. And we wanted to learn from that. So I got together 11 countries across the world to be part of what we call INEO and send their data to coordinating center in Toronto and to learn from each other and to see who is doing good in what, because not a single country was top on anything. And this is the result of outcomes that happens in different countries. So you see here Australia, Canada, Israel, Japan, Sweden, Switzerland, Spain, UK, Finland, Tuscany. And you can see from 2007 to 2015, the babies with adverse outcome are either static or increasing, meaning thereby more survival of premature baby has led to increased adverse outcome, except in Canada, which is the red line. We were worst in the OECD countries in 2007, and we are second best in OECD country in 2015. And that the only thing that can explain is the quality improvement national tale that I presented to you, that we worked together, we all worked hard in improving the outcomes of the baby. Not such thing is happening anywhere else. And that has led to Australia and Sweden to think that, okay, well, we are static, we are worsening. How can we improve the outcomes? This is the outcomes in 2007 versus 2016. As you can see, adverse outcomes in blue are 2007. This is the unit variation from 40% to 90% of the babies having adverse outcome. Whereas in 2016, the number has gone back to 20 to 70%. So it has significantly reduced in Canada. And you can see these graphs for individual countries, and you can appreciate the red curve on the left side comes from very, very, very few countries, which is statistically significant. However, we need to understand that this takes a long, long process. It's not an easy thing to sustain a national quality improvement outcome or improvement process across the country for this number of years. And it is the result of a continual data feedback, dedicated teams that each unit developed at their own site, training and support that we provided, continuous relationship and communication, adaptation of the protocol. We have changed so many things over time and facilitated those sharing of the best practices across the country. Because at an organizational level, we learned that there are so many factors that play a role: group dynamics, hierarchical nature, development of the unit as to where they are and where they're heading towards, and rationalization as to where the neonatal unit is in aspect compared to the entire hospital or the organization. And we learned this hard way. During this process, we went to the individual units and asked that what kind of culture you have in your unit that allows or facilitate the quality improvement implementation. And we understood that particularly for the neonatal intensive care unit, more the hierarchical nature that is present in the unit, there was a higher probability of implementing quality improvement activity. It's not that what I'm trying to recommend here, but one need to look at their own organizational culture and associate whether the quality improvement activity is happening, and there may be barriers that one may have to address that. What facilitated? I think dedicated individuals, dedicated teams at each individual site. They were willing to listen. They were willing to change the way they were performing, the way they were conducting their business. They adapted their protocols in a way that allowed them to learn new nuances as well as to learn new techniques. And then we continue to provide the training and support, as I mentioned. So I believe the success of our network lies in defining our purpose, understanding what we can from the data or learn or knowledge, and how leadership or authority accountability can be handled and communicated within organization as well as within at a national level. We ignored our power differential. At that meeting, everybody was voicing their concern, expressing themselves, but we, at the same time, we make sure that anybody is not privileged. We want actions over privileges. We know in advance what can be done, and we purposefully agreed for soggy consensus. We're not going to find that this is the one thing that everybody is going to follow across the country. The top-down approach in major organization or major systems or regions about quality improvement works to an extent, and after that it fails because of the fatigue. However, we let units to decide. We went for a bottoms up. We told them, you find out what is your problem, work out solution, and we will support you. We'll find you others who are having similar problem and help you to learn from each other and learn from differences and engage your frontline team. And that was the reason we probably succeeded. We did face some challenges. There is never going to be a cohesiveness. People wanted to do one thing even within a unit. However, we trained them to include everybody, keep the interest and enthusiasm going, because it's been 15 years. People get tired of every time 6 months you come with a new quality improvement cycle and ask them to follow. We continued to have leadership succession. I took over the network in 2011, 12. And funding has been challenges. We were fortunate enough for now. We will see what happens after the COVID, as we will be having challenges in securing designated amount to sustain the central activity. There were other challenges such as privacy and confidentiality, and convincing ethics boards that this is not a research we are doing to improve the quality based on what we know. And finally, at a unit level, there is always resistance. Nobody wants to change. Why do we have to change? And we had to work with those individuals to make sure that they understand the reasoning. Coming to close, I just want to say that neonatal care has evolved. In 1970s, we started having ventilation. In 1980s, we gave mother steroid. In 1990s, we identified surfactant. In 2000, we had nitric oxide and we had ECMO. In 2010, we learned slowly that you don't have to do everything, be gentler, avoid mechanical ventilation, and include family in the care. There is no new molecule that has come from 2000 onwards that changes the outcome or changes trajectory. It's how you do it better, and be consistent. And that's what has led to quality improvement being proliferating from 2000 to 2020. I must say, neonatal intensive care has evolved significantly in the last 25 years, and the only constant that has remained is change. How do we embrace and how do we implement change and improve the health of the babies and families? In the end, I would like to acknowledge a lot of people. All the individual sites, investigators, parents, our colleague foundation, the Premature Babies Foundation, which is an organization led by parents or patients, families, and the research center that I work with. A lot of trainers, a lot of group chairs, a lot of people who have worked in this, as well as the research center where we produce and send this report back to the individual sites. Thank you. I'll be happy to take questions. I hope I was in time.
You did wonderfully. Thank you so much, Dr. Shah. We have a few questions, but here's my prompt to anyone else who wants to ask questions to type them in the question and answer box at any time, and we'll go from there. We do have a question, Dr. Shah, from Linda, who says, data plays a big role in quality improvement, and she's curious to learn how you are able to get a data sharing agreement across the units. What tools did you use to collect the data? She'd just like a little more detail.
Yeah, I completely agree. Data is without data, you can't do quality improvement. So we have been collecting data from 95, and as you know, the privacy and rules and regulations have changed. So from 2010, we have institutional agreement with each individual sites to transfer this data on a regular basis, on a continuous basis to our coordinating center in Toronto. With the proviso that I cannot send this data out to anyone. The main purpose is benchmarking and research. However, individual research projects will have to go back to the ethics board at Mount Sinai, as well as the steering committee of the Canadian Neonatal Network to conduct any research or any other activity, but cannot send the data out. So yes, we had to do individual, and I can tell you that this is not only just for the national level. Internationally, I had to convince 22 lawyers from 11 countries to say that, look, I'm not going to go and find this particular baby, but we had to do the data sharing agreement with each individual sites. And it takes long. It takes a lot of back and forth between the organization to finalize the data sharing agreement, but we have it in place.
That is no small feat, I can imagine.
Yeah.
So as a former neonatal nurse, very former, and someone who works on a variety of different networks, this presentation was fascinating from both perspectives. What did the support that you provided to the sites look like?
Yeah, so I understand that two types of support. One, not two, multiple types of support. First would be moral support, as one could imagine, but I'm not going to talk about that. One is that during this period, what has happened is that every individual institution also wants to know when a particular unit says, "Oh, we are doing better," they say, "Well, better compared to what? What are your peers?" So that was a driver that every unit was driven to come back to the table and say that, yeah, we need to know how we are doing compared to others. The support that we provide is from the Central Coordinating Center is a unique platform that we provide them to collect the data. And this platform gets reviewed every 6 months, every 12 months to see that what are the variables or fields we want to retire, what are the new things that are happening that we want to introduce without increasing the time that it takes to collect the data. Because this is very labor intensive work. I mean, a unit with 1,000 admissions need a one full-time or 1.5 full-time person to collect this data. So individual sites took on the responsibility to support the local platform for local manpower to collect the data. We did not provide anybody any money except for the first 2 years when we started networking, 95, 96. Since then, the money for the particular person comes from individual units. They find money and they support the person. In return, they get his annual benchmarking, their function, other function, their own data analyzed whatever way they want. Central Coordinating Center was supported by the local hospitals, which were hosting the institute in the research center, as well as the province where it was hosted, plus the funding grants that we wrote and started to continue to get some funding from CIHR to support the coordinating center. However, this is always challenging, and every 2 to 3 years we have to go through the exercise that do we need to ask people to contribute now because of the activity we are doing, and those are the challenges we will face going forward.
Thank you. Have you focused any of the efforts on outcomes that perhaps have been identified by family partners as meaningful to them?
Yeah. So in the last 6 years, what we have done is join forces with Canadian Preterm Premature Babies Foundation, led by Kate previously and now Fabiana. And that's an organization which is run by the parents who had premature babies. So we have partnered with them, and currently they are running our follow-up network quality improvement, as well as they are our partners. They are at the table at every annual conference. Every site has one parent to send as a representative. So like 25 parents, 15 to 20 parents are sitting and telling us that, okay, well, yeah, you're presenting this, but what about this? I don't care whether my baby has BPD or not. I want to see my baby is free of anything around his mouth. So I can talk to the baby, I can sing to the baby, and I can see my baby. So we are, I'm not saying that we are completely there, but we are taking their feedback very seriously in any of the endeavor that we do in the last 5 years.
And apart from the neonatal outcomes, what network outcomes did you observe and change over time? And networks are often difficult to sustain, and what are the keys to the success of sustaining this particular network?
Yeah. So what are other network outcomes? So that's where we did a lot of health service evaluation, as well as we did an organizational evaluation. So we had researchers going to each individual unit, doing focus group, doing surveys to identify that what helps within their unit, what works within their unit to implement quality improvement. That's one slide that I showed. And feedback those units saying that, look, in your unit, this is what your frontline workers are saying, and this works, this does not work. It is not one recipe that works for entire Canada. So those, as well as we compared our processes, the outcomes as to what are we doing in terms of how many babies are exposed to antibiotics, why they are exposed to antibiotics, how can we reduce, how many babies are getting cold, how can we reduce. So those kind of process outcomes were seen. Sustainability is, I think, a real challenge, and engagement. So we basically meet every year, but at the same time, we continue to engage people in the conversation throughout year, at least by 4 to 6 teleconferences, and asking them, okay, what are you doing? Why are you doing? What have you developed? What have you learned? And disseminate this information to the other units. So other units are still, even if they are not doing that particular intervention, they're interested in knowing what happened to the other unit and what kind of activities they did. So by continuously engaging with, allowing them to interact with each other, direct or indirect interaction, asking them to visit each other to learn, is what has allowed us to sustain.
Thank you. Often with data sharing, with the kind of audit and feedback approach, organizations are resistant to being compared to peers sometimes, and sort of the negative perceptions that might put on their organization. Did you have resistance to the audit and feedback and the public nature public within the network nature of the data sharing?
Yes, so definitely. So the first slide that I showed about the site M versus site A or something, there was a public outcry for us to disclose what is M and what is A, and we couldn't because of our goals. In the 5 years up from today, I tried to see that our report just tells the name of the hospital rather than A, B, C, D, and ask sites that are they comfortable. Half of them were, half of them were not. exactly for the reason you mentioned, that it may be construed differently than what people might think, why my outcomes are not good as other outcomes, without knowing the context of the types of babies, types of environment that the particular unit functions in. So we still don't have agreement saying that, okay, yeah, we can have a public knowledge. However, I must tell you that over time, people have been so much open that when we meet in the meeting and I show the slide and they say, oh, I am the 23, I'm struggling, can someone help me? So within the network, within the confines of the people sitting in that group, we are open. Still not public, but we are open.
Understandable. How has COVID impacted this work?
Yeah, it did affect a lot. I mean, usually we get annual data completed by June for the previous year, because some babies are still in hospital. So they get discharged by April, May, if admitted in December. Mm-hmm. And then we complete the data collection in June, but certain people, data collectors, were not allowed to come back. So this, and when we complete in June, we come out with annual report by this time for the year 2019. However, we were fortunate that people were creative and getting some electronic help to complete the data collection. So we are only 2 weeks behind, so it has not affected. As far as the babies coming to the NICU, most of the NICUs remained free of babies, or probably 1 or 2 babies coming who had babies being exposed to mothers who had COVID during pregnancy. We will see what happens over the years. But it was more or less not challenged from baby perspective. It was challenged from the organizational perspective as well as the adults working. However, we strongly heard from the parents because the visiting policies were changed and a little bit more restrictive based on where you are. And they strongly gave us the message that that was not the right thing to do.
Thank you. And where to now next? What are the next steps for this network?
Yeah, so the next steps in the network are, one is looking at, we are not the randomized controlled trial network, but we want to go to how can we learn from different practices. And even today, if you walk in the unit, one unit will do this way and another unit will do this way, and they are all married to that. There is no evidence. There is nothing that one is better than other, but everybody wants to do this way only and then this way only. And there is some kind of information coming that one way might be better than other, but we don't know. So what we want to engage this platform to work it as a platform for randomized comparison. Having said that, not in a proper randomized fashion. So we will just tell the unit that, okay, you want to treat the babies by treatment A. Can you do that treatment A consistently for next 2 years? Another unit, do you do treatment B for consistently for next 2 years rather than changing here and there? And let's compare those two and then retire one. What it will bring is that it will allow us to have a scientific comparison between two different types of management, as well as consistency. And the consistency will be the trumping factor in this comparison, what we call comparative effectiveness research. That it doesn't matter what you follow, but if you follow that consistently, overall outcomes will improve. We may learn that one aspect is better than other, which is what we want to learn, and then see how it goes. So rather than doing a pure randomized comparison, we will be doing comparative effectiveness research using this vast platform and not introducing any of the treatment as a research treatment. Just follow what you do.
Thank you.
So that's one part. Second would be continuing the site engagement, because one of the things that worked, that everybody has said, is going to another unit, sitting there for 1 day and seeing how they work. And both the host and the visit, both units learned a lot. And that's what we want to promote more once COVID is over.
Wonderful. So that's the end of our time today. Thank you, Dr. Shah, for sharing your time and expertise with us. Thank you to all our members and other attendees for spending this time with us. We hope you depart with some practical knowledge to bring back to your organization or network. We have a packed fall Spark Live webinar schedule. Join us next week on October 14th at 11 Eastern for Adrift Between Systems, Transition Experiences of Youth with Mental Complexity in Their Families. And on October 15th, also at 11 Eastern, Ready to Work, Development of a User-Informed Online Employment Platform for Job Seekers with Autism. As well, registration is now open for our annual conference taking place virtually on November 16th to 20th. To register, visit our website at childrenshealthcarecanada.ca. It's always great if you can watch live, as your questions and comments enrich the discussion, but if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange network. So thanks again for joining us today. Thanks to Dr. Shaw for his presentation, Children's Healthcare Canada member Sick Kids, and our sponsor Mallinckrodt for supporting our webinar program, and hopefully we'll see many of you back here next week. Bye everyone.